populations. So please join me in giving a warm welcome as Dr. Machira shares his expertise with us today.
Thank you so much, Dr. Kapoor, for that kind introduction and invite me to this presentation. I hope you can hear me well and you can see my slides. Okay, all right. So we're gonna start the presentation and for the first several minutes, and then we have some discussion after the presentation. So my name is James Muchira, an assistant professor here at Vanderbilt University School of Nursing here in Nashville, Tennessee. And the topic for the presentation today is Generations at Risk is a nursing call to prevent cardiovascular disease across the life's course. And I'm so happy to have all of you nurses here so that we can have this discussion on how the nurses can really help in preventing intergenerational transmission of cardiovascular disease, mainly from parents to the children. Let me see how I advance the slides here. All right. So I have, four objectives, a little bit, maybe a lot of them, but we'll see how far we go. So the first one is we want to describe how cardiovascular disease persists across the life course. And we're linking this with the Sustainable Development Goals, and mainly is the two sustainable goals, number 3 and 10. So we want also to examine how the social determinants of health contribute to intergenerational cardiovascular risk, including global health inequities, which is more of the SDG 10. And then we want to identify what role does advanced practice nurses have in cardiovascular disease prevention to reduce cardiovascular disease globally that align with these SDGs. And I'll illustrate some of the things that I have done with other teams of nursing to disrupt these cardiovascular disease risk across generations. And then we'll have a discussion. All right, let's start this way. Now, we all have this slide somewhere. It's the Sustainable Development Goals from number 1 to number 17. And we know that these Sustainable Development Goals are a set of 17 global health targets adopted by the UN as a blueprint for peace, prosperity, and sustainability for the world. Now, one thing I've realized is that you look at poverty, health, education, clean water, these SDGs, they are very closely similar to what we call the social determinants of health, and they are really deeply interconnected. And if we understand these SDGs from the aspect of the social determinants of health, that can also help us to address them in our individual work. Now, back to cardiovascular disease, that's my area. So cardiovascular disease is a leading cause of global burden of disease. And also, if you look even at what we call the disability adjusted life years, is the leading by far compared with other chronic conditions and even non-infectious conditions, such that it is more than close to 15% of all global health disability adjusted life years. And if we want to reduce the burden of disease, we really have to target some of these conditions like cardiovascular disease so that we can target these in families, communities, and that will help in shaping life across the life course. Now, why focus on intergenerational risk of cardiovascular disease? By now, I'm sure you know of someone who has a hypertension or heart disease before. Let's start before age 50. Now, that was several years ago. Nowadays, it's very easy to get someone with a full-fledged hypertension taking medications at age 25, age 30. And what is happening is that there is a transition that there is early onset of cardiovascular disease from what used to be a disease of the old age. That is no longer that disease anymore. There is a lot of research that is showing that the risk of cardiovascular disease is actually passed silently from parents to children. A lot of studies, even mortality studies from children, very young children, show that children, if you look at the aorta dissection, you see a lot of arterial stiffness and atherosclerosis are starting from very early on, from neutral up to the first years of life. And the message here is that nurses, now that they are involved in, the life course prevention of disease at every stage of their life, from the delivery to the old age, they are prime position to intervene across the life course. And this is why one of the reasons why I've been very much interested in is this topic. And I know that nurses have a very big role in intergenerational transmission of cardiovascular disease. And we'll talk more about this as we go along. Now, talking about now why nurses must lead this effort. I looked at the two SDGs, number 3 and number 10, and we have these global goals of health, reducing non-communicable disease mortality, and reducing inequality. And I have just shown you that cardiovascular disease is the #1 global cause of mortality. And of course, the deaths are preventable. But the nursing role in this prevention is really the screening, prevention, and policy. And nurses can work at any level here. They can work at the screening level, the prevention, and that is both primary, secondary, and tertiary, and they can also work at the policy level. And I'll show you some of the things we have tried to do from the screening perspective, from the prevention perspective, and the policy perspective. Then reducing inequality. We know that, and I'll show you some of the slides, that cardiovascular disease is shaped by a lot of things. Some of them that deal with income, education, what we call the social determinants of health. And nurses' role here is to address the social determinants of health, empowering these families to be able to advocate the upstream causes of cardiovascular disease. So nurses really have a very important role in addressing this risk. Now we just talked about the social determinants of health, and just wanted to, I know this is in the public domain now, everybody knows about it, but just wanted to define that really the social determinants of health are conditions in which everybody grows in. Born, grow, live, work, and age. And interestingly, most of my research is now showing me that the social determinants of health and contribute more than 50 to 80% of the health outcomes. So in other words, the SDOH is really the causes of diseases. Because when you think about it, if you talk about exercise, which are cholesterol, all which are very high risk factors for heart disease, they do not just happen. They happen because of some reasons, because of these conditions where people grow, live, and work. And these conditions are shaped by distribution of money, power, and resources at the global, national, and local levels. Right now, we have a project that we are trying to address this distribution of money, power, and I'll show you how the nurses can work on that front. It's kind of the policy level. And it is one of the most difficult problem to address, because you see is a big problem that is at a global level, at national level, local levels, and it involves money and power. So it is something that would probably need just more than one hands to achieve. And I just say that the social determinants of health are responsible for most of the health inequities that we see globally, because they result from unfair and unavoidable differences in health status that we see within the country, because within the country, you see a lot of differences in the health status. And also between the countries, there's a wide differences in the health status. I'll show some of the slides to that effect as well. Now, this case study I have here, which I really want us to go through it, so that as we go through the presentation, you can remember this case study. Is a life case study for this individual I'm calling Jack. Is a case study that represents a lot of people. So it's starting from early life here, adulthood, and later life, and some intergenerational part of it. So we are talking about someone who is born, Jack here, is born in a location. Remember we talked about a location. He's born in a location, Flint, Michigan, to a mother, Tanya, who is a single mother and working multiple jobs. Now that just tells you a lot about what's happening in that family. Now, Tanya had preeclampsia, forgive my spelling here, and poor prenatal care. When Jack was born underweight and was exposed in utero to stress, poor diet, and secondhand smoke from the environment. And her mother had limited access to care, healthcare, and had untreated hypertension. Now, that by itself tells you what probably can happen to this baby as they progress through the life course. At adolescent and at adulthood, we start seeing overweight and hypertensive. By age 16, Jack becomes hypertensive, dropped out of the school to support the family because of, remember, her mother is working multiple jobs, probably he needs support. And in his 20s, he started working in physically demanding jobs and starts smoking to cope stress. Now, at age 45, Jack is diagnosed with heart failure and has a daughter by this time who has an early metabolic syndrome and lives in the same insecure neighborhood and high stressful environment. Now, what you see here is a cycle that coming from the mother here to the son and then to the daughter here, granddaughter, that without an intervention, something has to happen to break this cycle of cardiovascular disease. Now, this is how some of the intergenerational cardiovascular disease risk is transmitted. I'll describe a little bit more in details, but you see, it is not a rocket science. It's the environment. It is what is happening to where both the mother and the baby are growing in. And mostly the mother and the baby grows in the same environment. So what is happening to the mother's environment would really affect what's happening, the biology of what is happening in the child when they are born, or even before they are born. Yeah, if you have any questions, please feel free to probably chat or put it in the chat, and I'm sure we're gonna address it at the end of the presentation. Now, I wanted to have some polling here, but we'll just do this question this way. In the chat, if you can just put in there, which sustainable development goal do you think is most critical in order to address, in order to break the cycle of intergenerational cardiovascular disease? In that case that we have just went through, is it number 3 about good health and well-being, quality education, reduced inequalities, or sustainable cities and communities, or even all of the above? I'm not sure that I can see. Okay, let me see charts. Okay. All right. Okay. Yeah, okay. Good. So what's happening here is that I see there was some mentioned A, C, others mentioned E. Really, there is some aspect of, yes, there is some strong reasoning that there might be addressing one might help. But really, there is a lot of interconnected nature in these SDGs. So they are interconnected. Yeah, addressing one would help, but really because of the interconnected nature of these SDGs, you will need to address virtually all of them to kind of eradicate the problem. You can reduce the problem by addressing one of it, but really you need to address all. Let's see, I have another one here. Okay. Which policy level change would most effectively reduce the intergenerational cardiovascular disease risk? Is it universal access to prenatal? This is about policy. Access to prenatal and early child care, living wage and employment protection. Remember, there was a problem with employment, investment in healthy neighborhoods, infrastructure, national cardiovascular disease prevention strategies that incorporate social determinants of health. Let's see the chart again here. Okay. Right, all right. Yeah, looks like there's this, for this one, there's a general agreement that yes, it's about implementing all these policies. So remember, all these policies are capturing a certain point in the life cycle of transmission, and I'll show you that life cycle. So what we are trying to say here is that there is really needs to be all hands on deck. Is about access, is about employment, is about investment in healthy neighborhood infrastructure, is about targeting the condition itself. So all these will be really helpful, because if we just target the condition itself and there's a problem with employment, it's kind of recommending exercise strategies, and then probably people are not able even have healthy neighborhood infrastructure to do that, parks and access and so forth. Right. Very good. Let's keep going. So I wanted to have these few slides about understanding why there is an intergenerational risk. Now, cardiovascular disease, all of us know, is not an infectious disease. It is a non-communicable disease, and it's been called non-communicable disease for many, many years. So it's non-communicable in a sense that you cannot transmit it from one person to the other. Well, that is arguable, because cardiovascular disease can actually be transmitted biologically from parents to children through biological inheritance. There's a lot of studies about how that happens from gene to gene and epigenetics. And one of the biggest transmission is not actually biological, it's actually behavioral, the behavioral inheritance. So it's about and there's a lot of studies here about how parents model behavior, healthy behavior in their children. So that's the behavioral part of it, and it's one of the strongest risk mechanisms at which intergenerational risk of most chronic condition, not just cardiovascular disease, happens. The early life exposures, especially, and there's a lot of studies showing like the very early, especially in utero, that's when most of the intergenerational footprint is laid in the children. And some of the footprint is actually reversible, that has to do with epigenetics, is irreversible. Then there's a lifestyle modeling, which I've just talked about. The structural factors around the environment that the parents and the children live around, talk about poverty, stress, and access to care. All these are linked to intergenerational risk. If you look at this chart, probably, assuming there's no parent here, just someone who is born at infancy, childhood, and before pregnancy, they are growing in this environment. They are interacting with the health systems, the health policies, the demographic factors. They're interacting with the neighborhood and communities. But then what happens here is that there comes a time when this baby has to be born, and they are born in this environment here. So if the mother has adverse events because of what is happening here, that is affecting the baby, and there's going to be some risk that will be propagated and probably cumulatively happening all across the life course. The shared environment, the shared determinants here between parents and children, they contribute to this intergenerational transmission in a very big way. And I have this, let me see. Where is that chart? Okay, I probably have it on the next few slides. So one of the things I've been able to demonstrate in my studies is that the parents really, how healthy the parents are predicts the onset of a heart disease onset in the children. So I did this study from the using the data from the Framingham Heart Study. It's one of the biggest epidemiological studies of cardiovascular disease. And it showed that children of parents who have ideal cardiovascular health, and ideal cardiovascular health means parents who have like exercising, diet, not smoking, you know, what is it? There are 7 metrics of ideal cardiovascular health. Their children will have up to 10 years of life free of cardiovascular disease. So it's kind of lengthening or making the children are able to live 10 years longer without cardiovascular disease happening. Or parents whose parents who did not have ideal cardiovascular health, their children would have their cardiovascular disease event, let's say like heart disease, heart failure, stroke happening 10 years earlier. And one other thing I've been able to identify is that the risk is not just genetic, is from the modifiable behaviors around the parents and the children environment. And what we are trying to see here as well is that nurses can as well help very much translate this finding into prevention. This is just just a technical way of trying to say what I was trying to say. That you see the green line is of parents, most especially mothers and fathers who have ideal cardiovascular health. The time to which the children will have this disease onset is longer if the parents have ideal cardiovascular health. But even most interestingly was that for the mothers, this effect was even stronger for the mothers. So if mothers are more healthy, then the effect is stronger for the children. If the mothers have a poor ideal cardiovascular health, then the effect is even stronger for the children as well, having the similar type of cardiovascular health. So it looks like there's a higher linkage of parents and mothers and their children especially when during the early childhood years, when these children are very much in close contact with their mothers as caregivers. I wanted to define some key concepts here, which relate to intergenerational transmission. When you talk about, I think I've mentioned something about cumulative. So cumulative impact is where it occurs as a result of cumulative impact of social, environmental, and biological factors over time. Because remember, most chronic conditions, cancer, heart disease, these conditions they don't just happen in a day. They are very cumulative. They are very, they occur over a long period of time. So these cumulative risk factors, environmental, biological, and social, they lead, depending on the dose, so that's the cumulative impact. It determines whether someone will have this disease or not. For example, exposure to poverty, inadequate education, that is health literacy, poor nutrition during childhood can increase the risk of developing chronic conditions in adulthood. Then I talked about critical period, and these are as sensitive periods during the life, such as early childhood, adolescence, and pregnancy. This is where certain exposure of social determinants of health have very strong and long-lasting effects, especially in early childhood, pregnancy, or in utero and adolescence. Some of these impacts have very strong effects. They might be broken, yes, or stopped, but some of them have lasting effects on the health outcomes. Then the trajectory is the track where an individual, probably depending on what period in the life course, they experience these disruptions. That will determine how their cumulative exposures will behave in their life course. Maybe to show that I have this model, I always love using this model because it's a life course trajectory framework. On here, at bottom here, you have from childhood and adulthood up to the elderly period. This is a life course line here. And then we have the health disease outcome here. And then I want you to pay attention to this line here, which is the ideal life course, which literally no one attains this because you're trying to say at age 80 and above, someone here doesn't even have any elevation of blood pressure, for instance. That can happen, but in the real world, literally what happens is actually this average line here, the average life course. Or a lot of other times, this early vascular aging and early disease onset is actually happening. And so we are actually seeing much of this happening, this red line here, and less of even the blue line here. When interventions are performed during any time of the life course, say you start an intervention in elderly around age 70 probably, you only gaining a very short period in the life course. But then when you start an intervention probably around early adulthood, then you are gaining all this time from this line here. All this time you're gonna gain it here. But then there is even more another school of thought that actually starting this intervention early in childhood might shift these lines. Instead of having even this blue line, it might actually come very close to the green line here. Because at our childhood, what is happening here is that there's a lot of variability. And you see when individuals are born, the variability is very small. But this variability here of these lines here, trajectories, will be influenced by what is happening in the life when they are born. It is influenced by genetics, epigenetic imprinting, and other maternal factors like social determinants of health that are happening around that time. So if this model just helps us to know that at any time, nurses are available to help in prevention efforts of chronic conditions. And in the next slides, I'm going to be showing some ways that nurses can actually help in any of these trajectories to help prevent cardiovascular disease. So let's look at some of these examples. So probably I'm biased because I'm in research. So nurses are known to do high quality research. And I just put this table here to show you some of the clinical trials which we believe have one of the highest level of evidence in addressing cardiovascular disease. This is not exhaustive. This is actually in 2015. And you see there is a significant outcomes from all these trials: hypertension trial, dyslipidemia, lifestyle, hypertension, diabetes, smoking cessation, cost evaluation. Yeah. So there's a lot that nurses can do in research. And I wanted to show you, now that this is a global audience, I wanted also to show you that the number of clinical trials that are happening across the world is very disparate. And you see that most of the clinical trials are happening mostly in the high income countries, right? And in the lower income countries, in the Africas and South Asias, the green line here. So these lines, we see very little number of trials happening. And this is probably where everyone should also start focusing on, because some of the findings that we find in clinical trials might not be broadly applicable to everyone else across the globe. So we need to up our game here in terms of increasing the number of clinical trials in representation across the globe. Yeah, this was another one by countries, and you can see the disparity around the world here. So my message here is that one of the reasons why we have had a lot of problems in research, especially in clinical trials, is because of underrepresentation. Recruitment, and if you do research, you bear with me that recruiting any population is one of the hardest parts of the research process. Recruitment of under-resourced neighborhood or populations to increase diversity is another big problem, because there's a lot of there's just a lot of things that that need to be addressed in studies to reduce that. But nurses, I believe, are uniquely positioned to do this, to ensure clinical research is done in a way that it includes all the voices, women, for instance, diverse population, underrepresented populations, so that we can increase generalizability of these studies. We can help diversify the team and the trialist, education to patients, and community engagement. So really, by actively engaging the recruitment efforts, I believe that nurses can help increase participation of underrepresented populations, ultimately leading to generalizable and more impactful findings from our research. I'll present some of the work that I have done a little bit on this front, and I'll start from my work that I did in Kenya. So this work we did with a collaboration between the University of Massachusetts, Boston, and some schools of nursing in Kenya. This time I was a nurse lecturer in one of the schools of nursing here, and our students were very engaged in this work. And one of the things what we were interested in really is early screening, because what we realized is that there was a lot of undiagnosed hypertension in places that we never thought that there would be any high prevalence of hypertension and heart disease. So we were able to do screening and health education. We were able to address any cultural beliefs and barriers, and we are able to do prevention through local efforts and trust. And I have some photos here. I'm not the best in taking photos. This is me here, and this is one of the screening where we invited the community to come in for screening. See, these are some students that we had, and for these interventions, we did screening for high blood pressure, diabetes, and other risk factors for cardiometabolic disease. And interestingly, what we found is that in these locations, which was actually in rural locations where we thought that people might not have so many risk factors, we found that there's more than, you see, this is more than 50% of the people that we interviewed, or the people that we assessed out of 262. All these, more than 50% had more than either 2 or 3 risk factors for cardiovascular disease or diabetes. And this is one of the reasons why I was very much pushed in trying to do more of understanding the cardiovascular risk profile of individuals and try addressing these risk factors. So these are just more pictures. And this has been a while. This is since 2012. This is a number of years, more than 10 years ago. I probably have forgotten a lot of things. Now that is in Kenya. Let's look at what we are trying to do in the US, probably a higher income country. Now, in a higher income country, we also see that there is a higher burden of disease in marginalized communities. So let's talk about housing, income, stress, and food access are key drivers. We can still have nurse-led solutions, which include social interventions. And on this front, I've partnered with a community organizations here in Nashville, and we are implementing what we are calling a momentum hub. Is a mouthful. It's called mobilization, opportunity, and means for economic, neighborhood, and thriving unity and motivation. I've forgotten it already. but it is a care hub. Let's simplify. It's a community care hub that is aimed at building infrastructure to support. It's kind of, in short, is trying to reduce fragmentation of care or fragmentation of services or siloing of services so that someone who needs access to services can really access those services easily. If you look at this case here, Abby, a single mother in North Nashville, she needs food, job training, and some diabetes care as well. But the system is fragmented and overwhelming. She doesn't know where to go, who to ask for this, either food or work training or diabetes care. She doesn't know. So what we are trying to do with Momentum Hub is to bring all these organizations that are dealing with food, job training, healthcare, and so on, under one-stop shop, so that we can help navigate these services. So with one intake, just filling an intake online, Abby is able to be connected to these services. And we believe that this service, this hub, community care hub, which is an upcoming model of addressing community challenges, can help reduce stress, improve health, and help protect her daughter from inheriting the same risk that she is growing in. So I'm finishing here. So my message today, what is my message today? So my message today is that nurses can act as disruptors of generational risk of cardiovascular disease. We can help break the cycle, because we don't want a case where the parents have the similar risk of cardiovascular disease, the children and the children of their children and their grandchildren of grandchildren. That has been happening for many, many years. How we can address that is use data to target high-risk families and make targeted interventions, promote health literacy from pregnancy to adulthood. So looking at the life course, we can also help in leading culturally grounded interventions and policy changes. Looking at interventions from the locality where people are living, how can we address that? How can we also change the policies that are in those neighborhoods and different countries? We cannot advocate for upstream policies like the ones that are addressing social determinants of health, integrate trauma-informed and family-centered care. Trauma-informed, especially, we know that there's a lot of stress and trauma is very high in a lot of families, and I've learned that this recently when I've been doing a trauma-informed care for families. And then there's need for collaboration across different sectors and generations. Of course, I wanted to have acknowledgement for all the people that have been helping me to do this. I was a student. These four were my doctoral mentors, and they really helped me shape my thinking around intergenerational cardiovascular disease. In the audience, probably you might know some of these things, some of these people here. Marianne, when I came to Vanderbilt, she has been very instrumental as well in leading me to thinking more about intergenerational cardiovascular disease. So up to that point, I want to thank you for listening. I believe we have some minutes for questions. So thank you.